these trials don't go that far, so for obvious reason. But you want a sense of projection of safety and stability of a mechanism of action over that time. If you get someone who has the familial disorders like FHH or autosomal dominant hypocalcemia, these are clearly children, younger people, clearly have a very long life. Theoretically, this kind of information is important. That's not exactly the population to talk about, but by extrapolation, this drug could be useful in that population. So what's a good trial? I mean, it took, I don't know how many years of trials to figure out that estrogen caused trouble, and then it took multiple years and decades of information gathering to learn that it may not have been as bad as it was in the first time. So, what's a good trial is a good question, but 6 months is a good trial for any drug, and it's a standard of FDA would like in terms of stability and almost likely to guarantee it.
Yeah.
If you're dealing with a bone fracture study, you have to go out a few years. That's not what you're dealing with. So you can, by 6 months, demonstrate a stability of urinary calcium and blood levels, though, and that's clearly a longer study, but it clearly is a solid study, especially if you're likely to get small numbers of subjects. The number gathering, these are commonly used styles are really national or international studies gathering up. Not everybody has these patients to enroll, and then you have to enroll them and go through all the work of a clinical trial. So you'd have to gather up enough patients to do it. And if you don't have a huge number of patient subjects, then you'd go out a longer period of time in the trial. We have a little more solid footing in terms of a study being likable to the FDA.
Well, would you say that we'd have any trouble enrolling patients for a hypoparathyroidism trial?
If you go to, it depends on where you're going. You go to a large academic center. I don't think so. Around academic centers, where sharing of patients is potentially common. You can come up with somebody, enough people. It depends on how big of population you look. What your plan is to decide what is enough of an active patient load. So if you look at just the statistics, these are not highly prevalent, but every practice has a few, and again, you gather up enough interest in principal investigators, you're going to come up with enough people to enroll. So, but it depends on whether they're doing a large study, a phase 3 trial versus a phase 2 trial. Phase 1 for that matter. Phase 1 is different, but phase 2 and 3 are clearly, the FDA would have to determine what is the necessary number to treat to really determine a pass, and again, what's going to pass as a drug released, approved. I don't know exactly how they review this, because if you go back to some of the trials for the CRSRs and osteoporosis, there were numerous studies and small studies in numerous patients, but they didn't go to the level of I don't think maybe all the trials alone might not have been over 1,000 subjects. But the osteoporosis is easy. That's prevalent. This is not prevalent as a diagnosis. Yeah.
And are you aware of any centers of excellence around the U.S. that you would recommend for finding these patients?
There's a lot of them, yeah. I mean, just in the Massachusetts area, you go to the MGH, the one running the Bethesda Deaconess, you may come up with the UMass Medical Center has it. University of Connecticut has, I'm thinking, another has excellence in osteoporosis. Anybody who deals with osteoporosis would have an interest in this business. But some, particularly MGH, they have a department, the whole department, based on calcium disorders and bone mineral disorders. So they clearly are the biggies who go every direction. You're going to find a good excellence, center of excellence.
Great. Well, Dr. Kramer, this was an incredibly helpful conversation. I want to thank you very much for all of your